Hello, hi, my name is Caelan Taggart. I'm one of the research fellows working with Professor Mill's team in Edinburgh, and my talk is on risk scores in type 2 myocardial infarction. So, my declarations are there, and next slide. So just a bit of background to start on risk prediction in non-ST elevation ACS. As we know, there's loads of risk scores out there: GRACE, HEART, TIMI, Pursuit, to name a few. These have all been widely utilised and performed, derived from large trial and registry cohorts. And they're recommended for use by national and international guidelines, such as the ESC and in the UK, NICE. However, I would say that these scores are developed outwit or predate the era of high sensitivity troponin and are largely for patients with type 1 myocardial infarction. Now, over the last couple of days, we've had some great talks on type 2 myocardial infarction, some great research is coming to light. We know these patients, it's common that they're in increased risk of cardiovascular events, but we have to keep into consideration that they're a very heterogeneous bunch that require sometimes complex management to think about. But our aim was to derive and validate a risk prediction tool for patients with type 2 myocardial infarction. So the way we went around that is we had our derivation cohort of the high stakes trial, which you've heard a lot about over the last day. This was a trial of 48,000 patients in Scotland who turned up to A&E as suspected ACS, and with a fully adjudicated diagnosis of this cohort of 1,121 patients by 2 cardiologists independently and a third if there was disagreement. And we decided to go for a primary outcome of myocardial infarction or cardiovascular death at 1 year, and a secondary, more exploratory option of myocardial infarction or all-cause death at 1 year, because as we know, these patients are increased levels of frailty and things, and it would be interesting to see their overall level of non-cardiovascular death. So we began by doing Cox Regression Modelling to derive our score. This gave us a linear predictor for each of our patients, which we then plotted. We then took the expedient of this and multiplied it by the mean survival, subtracted all that from 1 to give us a whole risk of scores between 0 and 1 for each patient. And then what we did was took the median of that risk and took the lower quartile as low risk and the upper quartile as high risk, and everything else in the middle as intermediate groups. So we ended up with 3 groups: low risk, intermediate risk, and high risk. And then we externally validated our model in a Swedish population of 22,589 patients presenting to A&E with chest pain, of which 250 received, again, a doubly adjudicated diagnosis by 2 cardiologists of type 2 myocardial infarction. So this is the variables that we decided to go for. We went for these a priori based on clinical importance, and we feel that these are a good set of variables, as they are common physiological parameters that say how unwell a patient is. They also give good prognostications, such as things like troponin and age of how things are going to end up, but also modifiable risk factors, etc., or factors that can be optimized, certainly, for cardiovascular disease as well. We chose 9 as do not overfit our model. And as you see, if we can compare the 2 populations, they're pretty similar, with slightly more heart failure, hospitalization, and ischemic heart disease in the Scottish cohort, but otherwise pretty similar. So this is a cumulative incidence plot adjusted for non-cardiovascular death for a primary outcome of MI or cardiovascular death at 1 year. Sorry, of non-cardiovascular death it was adjusted for. And this illustrates the low and intermediate and high risk. And as you can see, after a year, the high-risk patients is up to 30%, which kind of gives a cohort, if you're in clinic, etc., if you felt that this could be used to target and optimize therapies. We also done a cumulative incidence plot. It's not adjusted because it's for all death of MI or all-cause death at 1 year. And you see the high risk here at a year. It can go right up to 50%, so a coin toss, really. And I think that's a kind of take-home message of how unwell and how bad the outcomes are in patients with type 2 MI, which I think is really the kind of take-home message of this whole thing, so that we can do some more. Our models had good discrimination for MI or CV death at 1 year, with an AUC of 0.75 and also an AUC of 0.75 for MI or all-cause death, albeit tighter confidence intervals, which we think was driven by a lot more non-cardiovascular events. We validated this in the Swedish cohort, and which showed equivalently good discrimination with an AUC of 0.6 and AUC of 0.81 for all-cause or MI. We performed calibration plots. These are plots that have been done looking at where they bootstrap the sample over time, and as to plot a smooth curve, as unlike Kaplan-Meier, which groups the risk And as you can see, the observed value and the predicted value are pretty similar, and the line crosses as well. So I think the conclusions really is we feel that our risk stratification tool provides good discrimination for cardiovascular death or MI at 1 year. And our further directions is we would hope that further modelling in this area and populations at type 2 would allow us to target more specifically cardiovascular disease in this cohort, optimise therapy, and overall improve outcomes. And just that, my acknowledgements, and I'd like to thank my team, our colleagues in Sweden, and the people in the Human Genetics Centre who helped us with our modelling. Thank you.
Thank you very much. Christian has a question.
So congratulations to your important work on type 2 MI. I have a question on how can you, or could you speculate on the challenges on how to define type 2 MI? Because your cohort was twice as large as the ones from Martin, however had more than four times the number of type 2 MI, although you both presented patients with suspected ACS. And I'm a bit concerned that you have included heart failure patients, which should be left out, because heart failure is a different cause of, let's say, injury, and usually should not be included in type 2. Could you please comment on this?
Yeah, I suppose when, is this on? Yeah, I suppose when we were comparing our initial populations, yes, it was 2% overall the population was high stakes, and 1% received a diagnosis of type 2 MI. However, the Swedish population was also younger by a significant amount when you took back to the right back to the base, nearly 5 or 6 years. So we do feel that a lot of that discrepancy in diagnosis was due to that. Regarding the adjudication process, the Swedish adjudication process was the same as ours. They had a discussion panel instead of a third cardiologist for independently excluded at the end. But we'd be quite confident that that data set would be reliable and that the type 2 MI is truly type 2 and not heart failure.
Can I ask you, so you created these models for type 2 myocardial infarction, then you validated them in the Swedish cohort, you calibrated them. What if you use your models and let's say apply them to type 1 myocardial infarction or acute heart failure? Do the models perform reasonably well then as well? I mean, how specific is it to type 2?
Yeah, I was playing around. I did it for type 1 myocardial infarction, and they did predict very well, slightly better actually than the type 2. And I think the reason for it is because it's such a heterogeneous population, and I don't think no matter how many variables you get, you'll always get a curveball with a patient with type 2 that may or may not have a further event. And I think that's something that we have to kind of put on barn door, know that these are really complicated patients, and you're always going to end up with some discrepancy of that.
Yeah. I see two questions in the back, one over there and one over there, and then we probably have to move on. So
fantastic talk, and very interesting findings. Just maybe I haven't seen it, but which variables did you include in your risk score? Was this baseline characteristic, those were the variables in it, first of all? Second, did you give different points? So just to say, if I wanted to use your score tomorrow, how should I use it? Thank you. So
I broke it into risk scores because I thought it might have been more of a better message for clinicians. But if you wanted to use the model, there is a function that we have in our programming where you can put in the variables, and then that'll apply a set of betas and give you an overall risk at 1 year by informing a nomogram. And then from that nomogram, then you'd be able to plug in which risk group the patient is.
So from your question, I guess, I mean, the variables that you used, continuous variables and so on, how did you model them? Because if you need to use a nomogram, it's usually because you model them kind of difficulty to use it. You need a calculator, right?
Yeah, exactly. Yeah, so you would make a risk. You'd have to make a tool. We would try and do that by overlaying a Shiny app over the models and then the betas, and it would do it all for you, and it would give you your score. But in terms of how we use the models, we did use things like cubic splines, but we tried not over-discretize and kept continuous models as continuous as they could be, just based on good statistical practice. So we tried our best with that.
Thank you.
Also, given the time, I propose we move on, because otherwise the General Assembly has to be cancelled, and I don't dare to do so. So, thanks again.
Final